The United States reaches a tragic milestone. 600,000 Americans now dead from COVID-19. And Africa suffers from a critical shortage of vaccines. We'll be looking at that too. Hello, I'm Anand Naidu, and this is The Heat. More than 600,000 people in the US have now died from COVID-19. That is more than any other country in the world. The staggering number was reached as the United States also surpasses more than 33 million cases of the deadly virus. Meanwhile, Africa is dealing with a major shortage of vaccines, with less than 1% of the continent's population fully vaccinated. Later in the show, we will hear from the Deputy Director of Africa's CDC, but we begin right here in the United States. Joining me now from New York is Dr. Calvin Sun. He is an assistant clinical professor in emergency medicine. Also joining us from Los Angeles is Abraar Karan. He is an internal medicine doctor at the Brigham and Women's Hospital and Harvard Medical School. And with us too here in Washington, D.C. is Joseph Williams. He is senior news editor at U.S. News and World Report. Thank you, everyone, for being with us. And Calvin, let me start with you. You know, this is a grim milestone. 600,000 people have died from COVID in the United States. And the big question, I guess, that'll be asked today and for decades to come is, could any of this have been avoided? What could the U.S. have done to avoid such a huge number?
Every time I come on, I always say the word deja vu. We could have done so much. Woulda, coulda, shoulda. I mean, we could have talked about this back in March, where the waves happened in New York City, and we could have locked down a little earlier, because that's what made the biggest difference for us. Once the lockdown happened, it took about 2 to 3 weeks for it to take effect, and then all the patient counts went down from the emergency rooms, and our hospitals prevented a total collapse of the system. And it's something that should have been enacted a little earlier, in my opinion, because we were truly overwhelmed. If you could stand in my shoes back then, about 1 year and 3 months ago, we really saw pretty much the beginning of the end. But you know, we could have prevented all this had we acted sooner and earlier. We had the infrastructures in place. It just wasn't activated by the people in charge. But now we're at a milestone that we never wanted to see. But also at the same time, like all stories related to Americans, the narrative of being American is that we counterpunch very effectively. It's the rate of deaths that are slowing because of our robust vaccination campaign. It could be better, but the fact that we were able to unroll the vaccines as early as last December, we are seeing the rates of deaths fall dramatically.
Right, and Calvin, when you say the infrastructure was in place at that time but wasn't activated, tell us more about that. What didn't happen?
Well, you go to the Javits Center right now, you can see the U.S. Army, the military, pretty much run a very smooth, well-oiled, in this case, American machine, and getting 10,000 people vaccinated per day in New York City at the height of our vaccination programs about 2 to 3 months ago. That was never put in place about 1 year and 3 months ago, where we were seeing a surge in New York City, and there was no military to be found other than the USNS Comfort, which only saw 179 patients over the course of 3 months, of a 1,000-bed capacity. The show was there, but the things were not being done. We lacked PPE. We couldn't have rolled out all this PPE in a stockpile, which we found out later really didn't exist. But all that could have prevented if we actually had activated the factories within the country to bring us all the PPE that we needed, and also build up makeshift hospitals and field tents outside the emergency room so that people weren't coming to the emergency room just for a test and then catching COVID and then going back and bringing it to their families and then coming back 2 weeks later with COVID and then repeat the cycle. Those things could have been possible had they been activated earlier. And we're seeing the effects of when they are activated, when the vaccine comes out and being unrolled to all these cities across the country, especially underserved areas. It's very encouraging to know that something's finally being done, but could have been better.
Abraar Karan, welcome to the show. Thanks for being with us. You know, as we heard from Calvin there, so much of this is about timing. What was done and when it was done, what was not done, and the impact of not having done those things at the right time. In fact, there's a study out by the National Institutes of Health which suggests that the COVID-19 virus could have been present here in the United States as early as December of 2019. That's a few months before it was recognized that it was in the country. And I'm wondering, did the CDC get it wrong? And if they did, what impact has that had?
Thanks so much for having me. Well, I think that, this has really shown us the importance of prevention and pandemic preparedness. And so, even when we had variants that were starting to spread throughout the country, our genomic surveillance programs in the United States were well behind those of the ones in the UK and other countries. And so for a lot of it, it's not really been a matter of if the virus is here, it's really a matter of if we are detecting it and the fact that it is here. And we'll be dealing with this a lot, especially with variant and especially with a large number of people that are still unvaccinated in the country. I'd worked on the WHO's independent panel for pandemic preparedness and response, and a lot of the research that we were doing essentially was suggesting that, in fact, those early detection systems are really, really critically important. I mean, it was challenging enough because we were in flu season, and so we were dealing with a novel respiratory virus that initially it was hard to tell what was going on, and if it in fact was a novel disease, a novel epidemic that was spreading in Wuhan. And so I think that as we do more studies like this and look at blood samples from January in different places of the world, we'll find that actually this infection was spreading in a lot of places earlier on. And one of the challenging things with SARS-CoV-2 is that you spread it with no symptoms initially, and you're most contagious around the day when you have symptoms. And so this makes epidemic control here very challenging. And if you talk to a lot of people I've talked to have said, looking back in January of 2020, I had symptoms that now I think were COVID. So, as we get more data, it will help us get better at pandemic preparedness and preventing this from happening again.
Joseph Williams, when we look at this number, 600,000 people who've lost their lives because of COVID, we know that politics had a lot to do with this. To what extent do you think the politicization of the pandemic was responsible for this very high number that we're seeing?
Well, it's hard to see how it wasn't responsible for that high number. As you'll recall, it became political from day one. I'm recalling the cruise ship off the coast of California that wasn't allowed to dock, and the people who were spirited away to God knows where, and what they happened and what was done to them. And President Trump's steadfast refusal to acknowledge that this was even a problem until we were on the precipice of disaster. There was the politicization of PPEs. There was politicization of quarantines. We had 50 states and 50 different programs on how to contain the virus. We didn't have a unified voice, and the red states were reacting differently than the blue states. So it has this overlay of politics over it. And even in talking about what responses did happen, were heavily politicized. And even now, we still have roughly, a third of the country that still needs to be vaccinated. Mm-hmm. And a large portion of those are in conservative states that took a long time to recognize that the virus was actually a thing, and were supported in that belief by the very president of the United States. So there was a lot that could have been done. Politics got in the way of much of it. Politics is still getting in the way to a certain extent, and it's all could have been prevented if we had a more a cohesive system of government, a government that was willing to work to solve a common problem than one more willing to point fingers and lay blame.
Right, and just one of the other things, and we've talked about this before on this program, and that is the disproportionate number of African Americans who've been affected by this pandemic. Is that, when we look at those numbers, is it still the case in the country?
It's still pretty much the case. And as much as we want the pandemic to be over, and as much as states like California and New York have reopened, it's still an ongoing pandemic. We're still seeing roughly 200 to 300 people die per day, which is a fraction of what it was at the height, but it's still loss of life. And a large proportion of those losses, those infections, are happening in the African American community, in part because vaccinating that community has been extraordinarily difficult. Not only do you have access problems, you also have problems with people being skeptical of the science behind this. You also have viruses being diverted away from places that need them, and you have the pressure to reopen, which could in turn create another cycle that will again disproportionately harm the Black community. And that's not even mentioning comorbidities, that's not mentioning access to medical care, quality medical care, and access to medical care that can keep you from getting sick in the first place and front-facing jobs that have to deal with the public and raise the risk of infection.
Calvin, of course, the United States has made significant progress in combating the coronavirus. The vaccine rollout has been ramped up pretty significantly, but we're now hearing about a variant called Delta. It sounds really dangerous. This is a variant which is highly transmissible. How concerned are you about that here in the United States?
I mean, I really always like to say it depends. I want to believe that all the vaccines are 100% effective against all variants regarding to preventing severe symptoms, death, hospitalizations. We found that Pfizer is the most robust so far in tracking and revealing their data. It's 88% effective against the Delta variant, and that's great. It's better than 0%. I wish that the other vaccines could be more forthcoming with their data. I think that takes time. I do believe in being responsible with releasing the data, not too soon, not too early. But at the same time, we just want to have that reassurance that Moderna has similar results, in retrospective analysis, as well as Johnson & Johnson's and even Novavax, which has just been releasing its data. It's been encouraging. But with regards to the Delta specifically, all we have so far that I can hang my hat on is Pfizer's. I'm a little biased. I got vaccinated by Pfizer December 16, 2021 of the first. So I'm pretty good for myself, but I really want the same kind of reassurances from everyone else who got different vaccines.
Yeah, I remember that day. We talked that very evening when you got your first vaccination. Abraar, many people, and as we've just heard, many people in the United States have refused to be vaccinated. They're resistant to getting that vaccination. And, we often hear people talk about herd immunity. And I'm wondering to what extent that is undermined by the fact that there are so many people in the country who say, no vaccine for us.
Yeah, definitely. I mean, it's definitely a challenging situation because, as with any sort of public health intervention, you'll have people that have early adopters who said, I'm ready, get me the vaccine. You'll have people who are waiting and watching, which some Kaiser polls had showed was actually a much larger proportion than the number of people who had said that, I'm not going to get this at all. And as, the vaccine hesitancy question goes, for a while, it had been placed on minority communities, saying that these are the communities that are actually hesitant. Well, polls show that actually it was white Republicans who were the most hesitant group in terms of getting the vaccine. And a colleague had mentioned that it had become largely politicized. Now, when we talk about something like herd immunity really was a concept that was developed and used more in infectious disease modeling, where you have a closed system, and it's within a closed system or a herd, like a herd of cows, for instance. You can say that if X number of or whatever proportion of cows get infected with a certain virus, that the chance for that virus to keep spreading on its own decreases and decreases because enough of them have some level of immunity. In an open system, like in a population that we have where people are moving across borders, there are new births and deaths, and there are these variants, reaching herd immunity per se is not that helpful of a concept. And we had written a piece about this in Washington Post recently. Instead, we should need to just keep focusing on the equity question, right? So as we'd mentioned, a lot of communities of color have been those hardest hit, and they're the ones with the least protection. We're not able to stay home during some of the toughest parts of the pandemic, don't have access to vaccines as they need to. Yeah. That's true on the global scale as well. As was mentioned, Sub-Saharan Africa, where I've worked many times, a lot of countries have less than 1% of people fully vaccinated, don't have access to the best vaccines. And I'm quite worried that with variants like Delta that spread more effectively, a lot of these communities that are unvaccinated and countries that are unvaccinated are going to be at very, very high risk of some bad outcomes.
Joseph, Calvin mentioned Novavax a moment ago. Novavax is a new vaccine. It's been tested, and I think about 30,000 people were involved in that test. It's proved to be effective, 90% effective from those tests. And if approved by the Food and Drug Administration, then it will be the fourth vaccine that the United States will have. And I'm wondering, will that make a big impact in the United States, or is the country already pretty much awash with vaccines?
It seems that the country is awash with vaccines, but there are two advantages that vaccine has that the other two don't. Number one is that it doesn't require extensive refrigeration, and it can be sent to anywhere and used at any time. It's fairly shelf stable, and that could be a boom to access issues that could help ease access issues in minority communities. The second thing is that it's got a 90% effectiveness rate, which is higher than some of the other vaccines. Correct me if I'm wrong, I think that's higher than the Moderna and the Johnson & Johnson vaccine, or certainly Johnson & Johnson. And people tend to gravitate towards the new and the novel, especially when it comes to the reputation of highly effective. But it will make a difference overseas where, as your previous guest is saying, if no one is vaccinated, we're all at risk. If other countries have populations that aren't vaccinated, that is running the risk of creating other variants, and those could very easily come to the United States and infect more people.
Right, Calvin, very quickly, I've got 30 seconds. The vaccines are working right now, but do you see us getting to a point where we're going to need booster shots?
I mean, we need booster shots for tetanus, typhoid, yellow fever, flu. I mean, I hope not. If you vaccinate enough people quickly enough, we may never need boosters again. But unfortunately, because there's always a persistent number of people who refuse to get vaccinated, it creates a chance of it mutating again and mutating again. As again, we're not safe until everyone is safe. And especially if you don't vaccinate the entire world, it can spread to Africa or people who don't have access to it and then come back to us and repeat it all over again. Hence why we need boosters. So practically, yes.
So when do you see that happening?
At the rate of it's mutating really quickly within 1 or 2 years, but I can't really make predictions right now. I hope I'm wrong. But hopefully tomorrow everyone gets vaccinated 100% and we don't need them at all.
Okay, and that's where we have to leave it. Thanks to all of you for being with us. And we turn now to Africa, a continent of 1.3 billion people where less than 1% is fully vaccinated for COVID-19. I talked earlier with Dr. Ahmed Ogwell Ouma. He is the Deputy Director of the Africa Centers for Disease Control and Prevention. Dr. Ogwell, thanks so much for joining us.
Thank you for having me.
Now, the African continent is home to 1.3 billion people, yet a very small number of people have been vaccinated so far. What can you tell us about the numbers, the overall number of cases, as well as the percentage of people who've been fully vaccinated?
As we speak today, we've crossed the 5 million mark of cumulatively those who've been diagnosed with COVID-19. And we've lost just over 135,000 Africans on the continent. Not very good numbers, but certainly much better than what had been predicted before. Now, the new tool to fight against COVID-19 is a COVID vaccine. And as we speak today, we have very low numbers that have been fully vaccinated. We are at about 0.6%. And yet our target is 60%. So the numbers are very low, and we are doing everything we can to be able to secure enough vaccines to reach our target of 60%.
Now, how severe is the lack of vaccines, and when do you hope to overcome that?
The lack is extreme. 3 things are important to note here in as far as trying to overcome that is concerned. One is that the African continent does not have an active vaccine manufacturing enterprise. And what we have cannot be able to address the need on the continent. So what we are doing is, one, we are engaging with the manufacturers, and we've been speaking with all COVID-19 vaccine manufacturers across the world so that we can be able to secure enough doses for the continent. Second is we are working very closely with the COVAX facility, which is really supplementary to what we are trying to do on the continent. And third, we are speaking to individual countries who have what I would call excess doses of vaccines, so that those can be repurposed for the continent. Ultimately, though, Africa must develop its own vaccine manufacturing capacity so that a problem like this will not have to be repeated in the future.
Now, as you say, getting a mass vaccination program underway is going to be a challenge because of the shortage of vaccines. But what about vaccinating frontline workers, nurses, doctors, other people who come into contact with COVID patients?
Every frontline worker, and particularly healthcare workers, are really a top priority on the continent as far as vaccination is concerned. Unfortunately, even those we cannot be able to fully satisfy simply because we do not have enough doses of vaccines to go around. And although from the beginning of the vaccination campaign on the continent, we prioritized healthcare workers and other non-health frontline workers, the interruption in supply of vaccines to Africa has greatly affected our ability to be able to protect even those healthcare workers who are taking care of COVID-19 patients. So the real big challenge here is access, and timely access at that, to COVID-19 vaccines.
Now, the United States, as well as other G7 countries, have pledged to donate 1 billion vaccine doses. They will make that available, and the World Health Organization says that Africa will be a priority for those vaccines. But we understand that those excess vaccines that the United States and other G7 countries will be donating will only be made available sometime in August, later this year. How will that delay affect the effort to get people vaccinated?
First, let me commend those countries that have made pledges to be able to support COVID-19 vaccination globally, and particularly in Africa. Second is vaccines by themselves don't make a big difference. What saves lives is vaccination, meaning the vaccine should be in someone's arm. Pledges are good. What is going to make a difference is that those pledges are turned into deliveries, and timely deliveries at that, so that the vaccines are here on the continent and being used to vaccinate Africans on the continent. Now, any delay results in a lot of risks because the virus then continues to spread in the community, and the risk of variants and more deaths and severe suffering continues. So any delay, even by a day, is really increasing the risk, not just for us here in Africa, but also globally, because we will not all be safe until all of us are actually safe. So we applaud the pledges. We, however, insist that deliveries are really what is going to make a difference. We want to see the vaccines here on the continent as soon as possible.
Now, China has provided vaccines to several African countries. What can you tell us about the impact that effort is making?
At the moment, the number of fully vaccinated Africans is only 0.6%. And this is all the vaccines that have been received on the continent, from China, from COVAX, from other sources, including ourselves as Africa CDC, the ones that we procured and distributed. That has only managed 0.6% of the continent. Although every little helps, we really need to be getting to 60% and not staying at just a tenth of a hundredth, in fact, of the target that we have. So every little helps, but it needs to come now in quantities that are actually going to make a difference to reach the herd immunity, which we estimate to be 60% of the population on the continent.
Now, we hear reports that Africa is in danger of a third wave, and this third wave could be caused by variants which are more transmissible. What can you tell us about that?
Indeed, our numbers cross-board have started inching up. And we have countries that are already in a third wave. We have others that are not. But generally, the trend is that the third wave seems to be coming. And with each wave, we saw the first wave and the second wave on the continent. The second wave was more severe than the first wave. And we are hoping that we can be able to arrest the third wave using vaccination and other tools of public health measures before it reaches those high levels. The issue of variants is a huge concern for us. And we are very actively doing genetic surveillance so that we can see what type of variant is causing the increased transmission on the continent. So far, although we have seen all the major variants that have been characterized across the world here in Africa, they are not yet the ones that are driving the third wave. And we want to keep it like that. So everywhere that we do sequencing and we see a variant has been identified, the governments are moving in very quickly and containing the spread of those variants. At the moment, what we are seeing is the original virus that is causing most of the increase in numbers, but we are watching very closely for these variants so that they do not cause even more difficulty in our measures to contain the virus here on the continent.
I want to ask you about one particular variant, and that's the Delta variant. We've been hearing a lot about this variant. It's been causing a lot of concerns around the world. It was first detected in India, and evidence has shown that it's highly transmissible. I mean, how big a risk is this particular variant for Africa?
Very big risk. And I think the lesson from India is that we should not allow it to spread within the community freely. That particular variant has now been detected in pockets on the African continent in a few countries, but the evidence we have is that it is not yet the one that is driving the numbers up. We continue to do sequencing so that we can be able to contain that particular virus. But the lessons that we are learning from India, we are taking seriously, and we are doing all we can to be able to contain the Delta variant and any other variant that is more transmissible than the original virus.
What about Africa's overall ability to deal with the pandemic? I mean, we've seen healthcare systems across the continent come under enormous strain. I mean, they were already under strain, but now with the pandemic, the challenge has become far greater.
Absolutely true. And that is why we are trying to keep the numbers low so that the health facility does not become the weak link in our response to this pandemic. I must add, however, that whereas the health facility, our health system, in fact, is strained, this battle is not going to be won in the health facility. This pandemic is going to be broken in the community, and it is personal discipline and our ability to follow public health measures. That is what is going to ensure that we break the transmission and we bring the pandemic to a stop. It is good to beef up our capacity in as far as the healthcare system is concerned, but it is better to prevent the spread of the virus and therefore not having to need the healthcare system as such. Indeed, if you look at the examples throughout the world, countries that had that thought they had superior healthcare systems, it quickly gets overwhelmed when you pass a certain capacity in as far as the rate at which severely ill patients are coming into the hospitals. So in Africa, our focus is to keep the numbers low, therefore to keep the number of those who need hospitalization low, and in that way, we do not have to have this double worry of not just a fast-spreading pandemic, but also the weak healthcare system. Meanwhile, we are strengthening the healthcare system across the continent so that it can be even better prepared, not just for this pandemic, but any other outbreak that may come in the future.
Dr. Ahmed Ogwell Ouma, thanks for joining us, sir. And that's it for another edition of The Heat. Thanks for joining us.